Well, I think we'll go ahead and get started just because we have a lot to get through, and we'll see if anyone's able to join. We are recording it, so we'll have this available. So thank you to everyone who's logging in um, and joining us for our Seven Sterling webinar series designed to give you, healthcare providers across specialties, pearls to help you feel more confident in supporting your patients with mood and anxiety disorders across the lifespan of women's health. And I'd be interested for those who have joined. I don't know if you can send a chat, but it would be great to hear, if you can, would love to hear kind of what your area of expertise is and where you're coming from. My name is Nazanin Homofar. I'm a practicing OB-GYN in Northern Virginia and the medical director at Seven Starling. My laptop is on its last leg, so the screen intermittently goes out. Crystal, can you tell me, because I can't see you right now, can you tell me if you can hear me?
Yes, I hear you just fine. And I can see
Okay.
you just fine as
Okay,
well.
great. My screen is white and black at the moment with nothing on it. So I'm going to ask
Lovely.
if Carly, if you're listening in, and if I go out at any point, just send me a text and I'll join on my phone. But I was saying I'm the medical director at Seven Starling, and Seven Starling is a virtual mental health clinic that treats those experiencing anxiety, depression, and trauma through fertility challenges, pregnancy loss and miscarriage, abortion, and postpartum. I'm thrilled to be joined by Dr. Crystal Clark, who, since the last time we had this webinar, is holding a different position. She is Associate Professor of Psychiatry at the University of Toronto and Associate Head of Research at Women's College Hospital. Congratulations, Dr. Clark, on this
Thank
new
you very
position.
much. I'm glad to still be with Seven Starling and doing these wonderful webinars.
I'm thrilled as well, and I know, and University of Toronto is very lucky to have you. You have dedicated your career to reproductive psychiatry and the advancement of maternal mental health. Dr. Clark works as a researcher, an educator, clinician, and thought leader. And as she mentioned, we're lucky to have her as an advisor to Seven Starling. I am not able to see everyone's, like, if anyone put anything in the chat after I asked the question, I'm not able to see it. So, Dr. Clark, feel free to
Yes,
interrupt me at any time and let me
I
know.
am monitoring, but no questions. Yeah, and no. And those who are just joining, just to repeat, please share where you're located and what your specialty is.
And in thinking about this month's webinar topic, I found myself kind of taking a step back to figure out what information I could use as an OB-GYN to help my patients decide if therapy is right for them. And I realize I speak about therapy very generally, and that if I had tools to talk about specific aspects of therapy, I could potentially help my patients understand the direct benefit for them when they're trying to juggle so much and make room for one more thing in their life. I was also curious to know the data for various therapy modalities in the field of reproductive health, which is why I brought the topic to Dr. Clark's
Yeah,
attention. And as always, I love that I'm able to call on you to help answer some of these questions.
sure.
So let's start with just the basics. I've heard the terms DBT, CBT, talk therapy,
Mhm.
post-traumatic. There's one, like, I've heard, what is it, like process group therapy. And I was wondering if you can briefly walk us through various therapy modalities, and even if I didn't mention some of them, and some key features of them.
Yeah, so I'll highlight the ones you have mentioned. There, and maybe a couple others, but there are a ton of therapies. So we would probably need a whole like 2-day workshop or something to,
Fair, that's
to
very fair. We're
give
just,
them all
we want
justice.
some pearls.
Yes, but I think CBT is a great place to start versus talk therapy because talk therapy is a great modality. It has shown to be beneficial for patients, but it's very different than some of the procedural or as they're often known as manualized therapies, such as CBT or DBT. And I'll explain what manualized means. But talk therapy is really, I think of it as more of supportive therapy. And supportive therapy it gives the patient the space and the outlet to share what's going on with them, especially things that might be distressing them or that they may not want to share with family or friends, or, maybe they feel like they're overburdening their family or friends with the things that are going on. They just want a safe space that's confidential, and with someone who is not judging them, non-judgmental. So it's not necessarily a focused therapy, so to speak. It may not necessarily bring about or it's not targeting any specific change. Doesn't mean nothing will change, but it's not targeting any specific change. And that's what makes it different from manualized therapy. So manualized meaning that there's often like, a guidebook or a manual to walk a therapist through. There's training, of course, that a therapist should have prior to using the manual, but the manual, the creator has created kind of a guidebook on how the therapy should be delivered, and it's usually targeting a specific change. So cognitive behavioral therapy, otherwise known as CBT, is a great example of that, in which the goal of it is to change cognitions and behavior, particularly unhealthy cognitions and behavior. So a perfect example of that would be OCD. And we see OCD in the perinatal period, especially postpartum OCD, but it's really changing maybe those thoughts that are, I'm going to throw my baby down the stairs. It could just be not a desire, it's a intrusive thought, which is obsessional, but maybe because the woman is fearful of that intrusive thought, she never goes down the stairs with the baby. So she just, she can't go down the stairs. So that's the behavior. And so now we're trying to change that thought so that it also changes that behavior, so that this woman can actually go down the stairs and not feel fearful that she's going to throw the baby involuntarily down the stairs or something like that. So that's an example. It's commonly used for anxiety disorders. So perinatal OCD would be another example, but generalized anxiety disorders as well. Really trying to change those cognitions that will in turn change that behavior. And sometimes we're focused on changing that behavior as well. Maybe, someone who has a phobia of flying or driving or things like that. Go ahead.
No. So that's really, we've divided up the therapy into support therapy and manualized therapy. And just to reiterate what you said, so support is just, you're just creating a space for someone. You're not targeting that specific change, but the manualized therapy is really when you're trying to change a cognition or a behavior. And so okay, and you gave the example of CBT, but DBT, please tell us a little bit more about that.
Yeah, and just to underscore what you said, it's with the manualized therapies, not only is it targeted towards a specific change, but it's using a specific procedure so a specific modality or otherwise therapy to make that change, which is why they consider it manualized, because it should be the same approach, with maybe some tweaks, the individual to the therapist, but a similar approach. DBT is dialectical behavioral therapy. And DBT is really more targeted towards those who have difficulty regulating their emotions. So thinking about someone who is experiencing extreme emotions, or maybe even be volatile emotions. It could be in response to interpersonal relationships or just daily stressors, but their emotions are just highly dysregulated. And we often, DBT is very well known as a treatment for borderline personality disorder, but it can be beneficial to many patients who are dealing with other disorders. Substance use disorders would be an example, even depression. It can be very helpful for that. It depends on the particular patient and what their needs are. But DBT builds on CBT. There are some CBT principles involved in DBT, but it also includes strategies for emotional regulation, mindfulness, and things like that.
Got it. And how about, are there other types of like therapy as well? I don't know, is there one called ACT or what are some other terms people might use for manualized therapy?
Yeah, no, great question. So just to highlight, according to the American Psychological Association, there are about 70 therapies.
What?
Uh, yeah, 70. So that's why I said we could have like a whole, I mean,
Yes.
they do have whole conferences around this.
Yes.
Um, but just to highlight some other core ones that others may have heard of, such as what you mentioned, ACT therapy is acceptance commitment therapy, and it's really more of a value-based therapy. Um, Working around or building on what people value and the behaviors that, kind of reinforce what their values are so that they can achieve a fulfilling life that is based on, what they value most, and not sometimes people, unbeknownst to them and maybe sometimes consciously, are doing things that are totally against their values. So it's kind of, some self-reflection, gaining some insights, and with the goal that they change their approach to live a more fulfilling life.
Got
So
it.
that's, yeah. But some other ones I would say would be trauma focused therapies, which, are very important, yeah, especially in the perinatal period, because we know that trauma itself is a risk factor for perinatal mental illness, especially postpartum depression. A lot of times people who have experienced trauma, this is a very vulnerable time for them, the perinatal period. So trauma-focused therapies, some people may have heard of narrative exposure or written exposure therapy, prolonged exposure, cognitive processing therapy. These are all different types of trauma-focused therapies
Okay.
that they use different approaches, but all getting at the same goal to change, help the patient not be scared of the memories or have avoidant behaviors associated with those memories of trauma. Ultimately with the goal to heal so that they're not re-experiencing these things during the perinatal period.
Fascinating. And how about with group therapy? I mean, I know I think my first exposure to group therapy was with Seven Starling. And I think and it took me a while to realize support, like there's a support group and then there's group therapy. And so how would you explain that to people?
Yeah, so very similar to individual versus individual, which when I think of individual, I'm thinking of like psychotherapy versus supportive therapy, like we were just talking about. So a CBT versus talk therapy. And so supportive therapy being, again, just that supportive therapy, and that people are getting together around a common, usually a common distressor or stressor. So again, might be postpartum depression or new moms or moms with kids under 2, or, they're all kind of focused on the same thing and coming together to learn how to better cope with different things. So they might get tips, they, might vent about, it might be a lactation support group, like the challenges around, they might be venting around the challenges around breastfeeding and that type of thing. Whereas group therapy is really typically geared towards a psychological problem. And again, it's focused on there being a change at the end of that group, those group sessions. And it's usually limited to 4 to 12 people, can't be less than 4, typically is too much if it's more than 12. It's usually very focused on a time period, so maybe it's 8 to 12 weeks. There's a limited time frame in which people meet. It's again a little more structured,
Mm-hmm.
and there's a goal for change. So maybe everyone's coming together around anxiety disorders, and there's some benefit because that you're not alone and you might learn something from other people, but it's led by a trained therapist who is able to guide the group such that they are getting some change towards the end, some skills, developing some new skills that allow them to handle their anxiety or whatever problem they're coming together around better.
That leads me to my next question, which was who generally performs therapy? I mean, are there certain types of therapy, for example, that a licensed clinical social worker can or cannot perform compared to, say, a psychologist? I feel like in OB-GYN, in the field of healthcare, we all have our abbreviations, and when it comes to
Yes.
psychology, I'm like, there are so many different abbreviations, and I don't always know what it means and what the implications are for the ability to practice.
Yeah, no, great question. For the most part, you will see PhDs, trained psychologists, psychiatrists, even some family medicine doctors, social workers who are usually licensed clinical social workers, so what we call LCSW, and even some counselors, which may be master's levels counselors out there who are doing therapy. The difference is, I mean, the easiest way to explain the difference is the degree of education, right? You know, the LCSW may have a bachelor's degree, but also may have a master's. Master's trained counselors typically have a master's, and then you have psychologists who have 4 years of got their bachelor's, and then they have a PhD, and they may have had some other training, and psychiatrists who have gone to medical school and as well as residency, as well as have a bachelor's as well. So the difference, though, I probably would say it depends on the focus of the different training. So it's not a one size fits all. You'll have some psychiatrists who completed residency training and had lots of therapy training as well, and others who won't. You'll have some psychologists who may have been more research focused and not so much clinically focused versus, or they might have been very clinically focused, not research focused. So they're going to have lots of clinical experience and training and lots more supervision than maybe your LCSW, who did not do as much training as that psychologist who was clinically focused. And then the master's level counselor, a counselor that's not a master's level, I'm not as well versed on how well their training is if they're not at least master's level. So I would need to look into that, but I would at first glance be a little concerned as to the complexity in which they could handle. Even with the LCSW, it depends on where they have been supervised or what type of population they've been working with. So so I say all that to say that, I mean, many can run the gamut. I can't say that there's one person who can't or can do one type of therapy or not. It's really about what type of experience and training they've had. And so when you're looking for a therapist or looking to refer someone to a therapist, that's pretty much what you want to ask is, where's your specialty? What types of modalities are you trained in? What type of experience have you had? And those who have not gone to graduate school, you might even be more inclined to, ask what type of clinic have they worked in and who supervised them, earlier in their training. So
that makes sense. And I think, and that's helpful context. So it sounds like if you have, most everyone is going to be able to, if they have the training, be able to provide either the manualized or supportive therapy.
Right, exactly. And as I said, there's 70 therapies. So some are going to be like, oh, trauma-based therapies is my thing. Right. Others are like, I'm a CBT expert. Somebody else is like, oh, I do psychoanalysis. That would be the one thing I'd probably say most master's level clinicians and LCSWs don't do, but they can. It requires a lot of training. A lot of psychiatrists psychologists aren't even trained in it. But yeah, it's really just asking like, what is today you don't see as many people who just do a lot of integrated therapy, which I think is a great model where you're pulling in different pieces and principles of different types of therapy modalities. but you don't see that as common these days. Like, there are definitely those out there, but more often you're seeing people who have kind of picked a few that they're really masterful at.
Hmm. And that actually, that integrated therapy brings me to my next question, which is, in the world of reproductive psychiatry, are there any thoughts on modalities that are more effective? For example,
Yeah.
what is CBT versus talk therapy utilized when it comes to perinatal mood and anxiety disorders? Or uh, what do we know about potentially integrated therapy in this field for someone who had like birth trauma?
Yeah, no, CBT has definitely shown some promise for the perinatal population, and with more recent studies showing, definite improvement in patients who have CBT versus, standard of care or talk therapy. Others that have shown good effect is interpersonal therapy. So it's really, how you are relating to others, which I do think if we just think about the basics of that, how your relationships with others when you're postpartum, relationship with your husband, with your family members, setting boundaries, those types of things. IPT is the acronym for it. That can be very useful for some patients. And
Hmm.
again, we're coming back to, what's going on with that patient, what are their symptoms, and what are the relationship issues or psychosocial factors, or what else is playing into those symptoms where we can use a therapy modality. So IBC won't work for everybody because everyone's not having relationship challenges or having trouble relating to others. CBT won't work for everybody because everyone's not needing to change a particular cognition or behavior. So
That makes sense. And how about like talking about the integrated approach and combining therapy modalities? What do you have any data about individual and group therapy combining that, or
yeah,
what we know about other integrated therapy results?
I don't know the specific stats on combining individual and group therapy, but it is commonly done. You see it most often, I'd say, well, not most often. I think of it like when I think of couples therapy, often we're recommending that each person have an individual therapist. You don't have to do group therapy or have to do individual and combining with group therapy, but I do think it can build on each other depending on the particular situation. And so it could be very effective together. And integrated therapy, I actually love integrated therapy because it allows you, if you know a lot of the different principles and are able to kind of use them as you need them, people aren't cookie cutters. So you're like, okay, today CBT is not, those principles aren't really helping that patient. Let me try something else, let me pull another tool out of my bag and see if this approach helps. And maybe that approach doesn't help. So it's almost like, switching medications. Like, yeah, that's not working.
Yeah,
let me try this. And I think it can be very effective. And I personally would love for everyone to be doing integrated therapy because if you just need to stick with CBT, then you know how to do that. And if you need
yeah.
to pivot, you know how to do that too.
And I think, and I'll talk about it briefly later, but I think we're proud at Seven Sterling that we use a combination of therapies as well. That I think, as we gather more data, we'll see hopefully will be effective for our patients.
Yeah.
So I'm excited
Yeah.
about to see those results. How would you talk to someone about therapy who might be resistant to it?
Yeah, great question. I'm glad to know that we're getting a little more traction with therapy these days.
Mhm.
The pandemic that's been one good outcome of the pandemic.
And
But
normalize the discussion very
yes,
much, I think.
absolutely. And so when I'm talking to patients about therapy, I've heard all types of things like, how is someone going to help tell me what to do or help? They can't change my life, It's not meant, I tell people it's not gonna take away the problem. There's no pill or talk session or group session that's going to you know, give you more money all of a sudden, or, you know,
Right.
take away any particular issue. But, you know, it's about coping. It's about building that buffer, about um, strengthening your skills so that you can reduce the stress and the burden that you're carrying as a result of whatever the patient is going through, or as a result of the mental illness that they're dealing with. And it can be healing. You know, I just tell people, let's give it a try. You know, just do a full 8 to 12 sessions with someone. If it doesn't work, you know, of course, I tell them make sure they have a good rapport. They feel like they trust the person they're working with. Because if you don't trust the person or you don't like the person, then everything is going to be downhill from there. But yeah, make sure they have a good rapport, and keep looking until they do, and then try a good full 8 to 12 sessions, you know, consecutively. It shouldn't be like I tried one month and another 3 months later. It has to gain momentum, so to speak,
Mhm.
and and then see if it's, you know, it's helpful for them. Most people end up finding that it's helpful.
I think, and how about to the person? I mean, most often the challenge I face is someone who's pregnant, um, who feels really overwhelmed and has scored on, has scored
Yeah,
a high enough score on their GAD-7 or PHQ-9 or EPDS where I know they would benefit from therapy or even postpartum. And yet when I bring it up, they're like, I just can't add anything else. Like, what do
yeah,
and I liked the idea of saying like this could help you cope.
yeah.
What's another, like, what one thing I love about our conversations is when we come back with a phrase or some questions we can use. What else would you say in this scenario?
Yeah, no, because I think you highlighted that well. I get a lot of patients who say, I can't do like one more thing. And I have to say that, you know, we're very fortunate that telemedicine has become much more integrated in our standard of care. So it used to be that, okay, it's like I got to get out of the house, pack the baby, you know, that's just way too much. And honestly, I felt, you know, bad even asking someone to do that, because I mean, how do you argue with that? But I do think today, you know, like, hey, the baby can be sitting there with the rocker, you know,
Mhm.
um, and we can try to do this session, you know, in a great ideal scenario. You have a loved one, a partner, sister, mother, neighbor, shoot, friend who can take the baby for just that hour. And I encourage the self-care, because the self-care, baby's not going to do well if mom's not doing well. So I
Mhm.
encourage the mom to think of it as also caring for her child. And I think you have to get at the patient that way, because they're often thinking, I can't do something for myself because I have to care for my child. And I'm telling them, you have to do this for yourself so you can care for your child, so that your baby can um, get the best of you.
I think that's an amazing way to end. So, therapy in these scenarios is going to help you care for you and for your child so that your child, as you put it, can get the best of you. That is beautiful. And I repeat it so I can remember it and get it into my own lingo so that
Yeah.
tomorrow I can potentially use it when I see a patient.
Wonderful, wonderful.
Dr. Clark, thank you so much for all this information today. And I don't know, my screen is still blank. Are you seeing any questions from the participants?
No, I'm not seeing any questions. Yeah, no, I'm not seeing any questions.
Well,
Just
if
double.
anything comes up, let me know. But we are so thankful to the providers who joined us today, and we hope you found this session engaging and informative. I briefly mentioned this, but for those of you who are interested, Seven Starling uses a combination of talk therapy, of acceptance commitment therapy, of CBT, DBT, mindfulness, and process group therapy to address our members' mental health needs. And in fact, we wrapped up our most recent outcome study, and are thrilled to report that 92% of Seven Starling patients feel better within 2 months of starting our program. I also wanted to let everyone know that as of this month, we are shifting to accept direct referrals from OB practices. So when patients have agreed to the visit that they would benefit from mental health care, um, I was reading through some numbers by a group called HEDIS, and I'm sorry, I'm forgetting the abbreviation right now, but there was a big study that came out that 50% of people who screen positive for anxiety and depression postpartum never receive follow-up. And we know that for busy parents, especially those overwhelmed by their symptoms, setting aside time to reach out and set up appointments can be near impossible. So in order to enable seamless care, we will be accepting secure direct referrals via fax, phone, email, web, or electronic medical record. So for more information on that, you can respond to the newsletter or email practices@sevensterling.com. And hopefully everyone heard that gem of a statement that Dr. Clark made about how to convince your patients potentially that participating in therapy will make them well so they can care better for their baby. At Seven Sterling, we are committed to providing the full spectrum of women's mental health care and would love to support you and your patients. So you can always check out our website, sevensterling.com. If you like this webinar, please subscribe to our newsletter so we can keep you informed about future events. And I hope everyone has a great night and happy holidays. We'll see you all in 2023. Dr. Clark, thank you so much for your time today.
Yes, thank you for having me, Dr.